So lower back pain, second most common cause of, second most common neurological complaint. Someone comes with something neuro, right? It's usually back pain. First option is headache. But after that, we got lower back pain, right? $100 billion per year spent on lower back pain, leading cause of disability and missed work, and that then results not only in healthcare costs, but also lost wages and lost production. All of, on the business end, it's important that we fix lower back pain. There's different types. There's acute, subacute, and chronic, right? Chronic back pain is 12 weeks or more, right? They got 4 months or 12 weeks of lower back pain. You now have chronic lower back pain. So we want to try to fix it in the first 4 weeks. That's usually our opportunity to turn around the back pain. And we have different medications we can try. We have different strategies we can intervene with, but we want to make sure we are trying to avoid going into a chronic phase of back pain, right? So 60 to 80% of people with lower back pain will self-resolve in 4 weeks anyways, right? And then I think it's like 85% actually. It's 60 to 80% will actually develop lower back pain in their lifetime, right? And then of those people that develop lower back pain in the first acute lower back pain, they're going to develop chronic, was 1 in 5. That's like 20%. All right, 20% of those who get acute lower back pain will develop now chronic lower back pain. That's going to lead to healthcare costs and all kinds of other bad stuff, right? So what else on that? So it's unpredictable when it can happen, but there are certain things that we can do to fix it, right? So what causes lower back pain? Most commonly, 7 times out of 10, 70% of the time, it is non-specific, right? They just moved funny, right? They did some heavy lifting. They did something that caused a strain on the muscles of the back. There's no problem with the spinal cord. There's no like compression fracture. There's no arthritis of their spine. There's no subluxation of the spine. What is subluxation? Misalignment. Yeah, it's like a, what's the word? I just lost it. It's displaced. It's a, when it comes out of the joint, the ball saw comes out of the joint, what's it called? I lost it. Dislocation, there it is. So it's a fancy word for dislocation, right? It's a subluxation. Okay, so it's none of that. It's just the muscles have been moved around, right? The muscles are sore, the muscles are tight, the muscles have been strained, right? Because the muscles are attached to the bones, and the bones will then pull and it can cause some discomfort, right? So obesity, heavy lifting, we got pushing, bending sideways, some twisting movements that will cause issues, right? And then what else? We got postural issues. So you have bad posture for a while, that can cause back pain. We have smoking, causes decreased nutrients to be absorbed, and that will cause the discs to get weaker and weaker over time and degenerate actually, and that can cause some pain. But usually it's non-specific. 7 times out of 10, lower back pain is caused by something muscular, and muscles heal. So that's why in 2 to 4 weeks, it should fix on its own. Okay, and 30% of the time, it is something mechanically wrong with the spinal column, right? So when I say spinal column, I'm thinking vertebral column, the whole shebang, right? And what is the whole shebang? We have what? Let's put this out of the way here. All right, so we have the whole spinal cord here, our whole vertebral column, and down the middle, right? We have our what? Spinal cord, right? It ends about L5 or so, L4, L5, usually around L3 actually, but the spinal cord can get compressed, and that's the worst case scenario, where you have central spinal cord stenosis, right? So the spinal cord itself gets stenotic, right? The bones are getting overgrown, or you have a tumor that's overgrowing, or you have a squishing of that central spinal cord. That's going to start causing some significant problems, right? Because what does the spinal cord do? It sends out motor fibers, and incoming are sensory fibers, right? So they're going to have lack of sensation, right? So that's called what? Lack of phasia or anesthesia, right? At first they'll have paresthesia, where they have pins and needles, right? Who's in there? Anyways, we have then we have motor symptoms, right? They don't have motor activity. What's that called when you have no motor activity? Paralysis, right? First it'll be weak, and then it'll be flaccid, right? So we need to be able to assess if someone is weak, right? How do you assess someone's weakness? Strength. There's strength assessment, right? It's a scale of 0 to what? 0 being flaccid to 5, right? 5 being strong, no deficits, right? So anyways, we can herniate is a really common thing. So we can herniate centrally right into that spinal column, that's not good. That's going to be a worst case scenario, right? Usually when we herniate, it pops out, and it pops out against some of these nerve fibers that are coming out of the spinal column, right? So these nerve fibers are going to certain different dermatomes, different levels, right? So L5 is going to like the front of the leg, right? And there's the back of the leg. There's the toesies, right? There's the S1, right? At the level of S1, it goes to the perineum. At the level of T5, it goes to the heart. The level of C3, 4, 5 keeps the diaphragm alive, right? So there's all different levels that will have a effect, right? That can become symptomatic. Okay, but usually with lower back pain, it's going to be causing some leg pain, right? At first, you get a lot of pain because we're having increased firing and inflammation locally right here. All this is not just kind of just squishing it and just like poking the button. It's actually going to start causing inflammation. This little nougat center right here, right, of the vertebral column, right, that keeps the vertebra separated, because you want your vertebra not just be rubbing on top of each other, right? It's like cracking knuckles and it's going to rub against each other. It's not going to be fun. That's going to cause inflammation in of itself, which can happen with age when we have a lack of water inside that vertebral column. But in this case, we popped out this little nougat center that's inside there, right? And that little Snickers, right? Little nougats, right? That's going to pop out, and it's very, very inflammatory, right? It's going to cause pain in the back, but also it can cause symptoms on that specific nerve root, right? So you have two nerve roots, left and right, right? And those eventually come all the way to the spinal cord, which is worst case scenario for herniation, right? So herniation is where the annulus is the outside layer here, right? And that weakened because of obesity, it can weaken because of an injury, mechanical injury, something caused it to pulpose. I'm thinking of pupusas now. It's causing it to propel, that's what we're looking for, propel the pulposus forward, right? So this nucleus just squeezes out, right? And it starts compressing the local root, or worst case scenario, it compresses the spinal cord itself, and obviously one is worse than the other, right? That nuclear material is irritating, right? Causes inflammation, and it can impinge the nerve roots, or it can impinge the spinal columns. The nerve roots are on the side over here. The spinal column is in the middle, right? If you look downward right here, spinal column is right there in the middle, right? In the top right, that's the spinal column, or we can impinge the nerve roots on the sides, right? So herniated disc is the most common reason. So you squeezed out some of this material inside the vertebral column, and it's squeezed out and it starts compressing the nerve roots or causes inflammation. You can have bulging discs and you can have herniated discs where everything is herniated outward, and now it's actually causing a lot of symptoms, right? So that's a common reason, a mechanical reason for lower back pain. Another mechanical reason is traumatic fractures, like a car accident or falling from a ladder. It's causing a vertical force, causing fracture of the actual spinal column itself, or a compression fracture. Someone who has osteoporosis, who has lost 2 to 3 inches, right? Or someone who has bone cancer, someone who has metastasis that makes that bone weak. They have bone, because vertebrae are bone too, right? The osteoporosis does not just go to the hip, it's all over the body, including the on the spinal cord. It's the vertebral column that's getting weakened here. And as that compresses, that can start compressing nearby structures, cause inflammation, and it could even also cause some nerve root impingement or spinal cord stenosis for that matter. Okay? So vertical compression, such as osteoporosis. And what can happen is with age, that's called spondylolisthesis. That's just displacement. Right? Actually, sorry, that's actually just a displacement. Actually, I didn't focus on that, so you can disregard that one. But spondylosis, they sound similar. Spondylosis is what happens with age. We mentioned the water content can slow down and get dehydrated over time. So the space between the discs starts getting thin, right? And as it's getting thin, it starts getting inflamed, and the discs start working on each other, not only at the disc level, but also at the fascicular or the facet level, where all these little facets that intertwine between the vertebral column, but this inflammation itself can start getting more inflamed and more inflamed and more inflamed, and then it starts breaking apart and it starts forming fragments that then merge together, and then your spinal column looks like a bamboo. I thought I had bamboo on here somewhere. Anyways, So it looks like bamboo over time. So it starts getting just frozen together, right? And it's usually in a flexion situation where they are all flexed and they get kyphotic, and they have you have a spinal column that does not work great. So they have to go in there and they have to break it apart and put in spacers and get spinal surgery. There's really no fix to that, right? And then with age, it can eventually lead to this crazy bamboo situation, which is the ankylosing spondylitis. Spondylosis is just the wear and tear due to age, and then eventually it could get so arthritic, so it's so much grinding on itself that it can lead to a inflammation or an itis, a spondylitis. Okay, and then stenosis is our worst case scenario. So we have narrowing and compression of either the nerve roots on the left and right, or centrally on the spinal column, right? Oh, it kind of looks like bamboo, but I didn't highlight it great. On the next slide, we kind of pointed out. Either way, we're stenosing those nerve roots, or we're narrowing the area that the spinal cord can go through, and then it starts getting inflamed, and then it can't do its function, right? So we lose sensory motor function. It's like a big deal. Well, it can lead to permanent disability, right? So it could be degenerative changes, like we mentioned, or it could be mechanical reasons. Due to a herniated disc can herniate onto the nerve roots, or can herniate centrally onto the spinal column. Okay, and we mentioned scoliosis can definitely cause some pain. That could be a congenital reason, a mechanical reason why our spinal cord is being compressed, right, or causing lower back pain, right? So with lower back pain, you don't have to worry about it. It usually gets better in 4 weeks, but there are some what are called red flags. So red flags are things you'd have to immediately get imaging for, an MRI or a CT scan. X-ray maybe, but usually MRI is the best thing we can do to see if there's something causing stenosis, something causing infection, something causing something like a tumor or something. So these are what are called red flags, right? The mnemonic is tuna fish, okay? So T is being trauma, right? Someone has like massive trauma to their spine. It's like, oh, you're cool. Just wait 4 weeks and we'll see how you do, right? No, if they have a traumatic history, it's like I got lower back pain. What happened? I got in like a 24-car pileup. Oh, well, shoot, come follow me. Let's go get you a scan, right? Let's give you some more medications, right? Another thing is unexplained weight loss. Well, shoot, what does that make you think of? Cancer, right? So it could be metastasis to the bone, or rarely it could be bone cancer, right? Most commonly, it's a bone cancer, it's a metastasis to the bone that's causing bone breakdown locally, right? It got cut off. I think the projector. I didn't hire the projector guy to fine-tune this morning. Either way, this I think I brought it up later too, but BLT with a kosher pickle and mustard and mayonnaise is the mnemonic for things that metastasize the bones. So B is breast, L is lungs, right? T is thyroid cancer, K is kidney cancer, P is prostate cancer, also testicular cancer, and MM is multiple myeloma, right? All that's going to be due to like unexplained weight loss, right? You have unexplained weight loss, you got lower back pain, you might have cancer. Let's do some more studies. You're not going to wait 4 weeks because they might be dead in 4 weeks because they have metastatic cancer. Okay. So the other key thing is neurological symptoms. So we'll talk about those, I think, on the next slide. These are like severe neuro symptoms that you can't ignore. Right? Back pain is neurological, and they might have a little decreased strength, but if they are incontinent, that should never be a thing. You should have lower back pain and incontinence. Say, just go to CVS. They have chucks. You're fine, right? No, that's not okay. We need to recognize that is a priority. That they have a possible impingement of the spinal column. Okay, age greater than 50, right? That's a problem. We got fever. That means we have an infection, right? We have an infection in the spine. That's not good. So we have to recognize that. I can't say, oh, just wait 4 weeks, you might feel better. No, they need antibiotics. They need to get a scan to see what it is. They might have to go in there with surgery and take out the source of infection, right? An IV drug user is high risk for infection as well, right? Steroid users, right? So if they have steroid use and lower back pain, they probably at risk for what? For a compression fracture, right? And you can't just let that ride. They might have a compression fracture, might be impinging things, and they might need surgery to fix that, right? And last thing on the list that fell off the slide there is history of cancer. They have history of prostate cancer, and they have a lower back pain. Well, it might have metastasized, right? Other things to be really super alert to is that causes back pain is like aortic dissection. Someone's aortic dissection, it's radiating to the back, right, and causing back pain. You're fine. Just wait 4 weeks, right? You're good, right? But your left and right arm have different blood pressures. Maybe that's normal. I don't know, right? You have something neurogenic going on. No, they have a dissecting aortic aneurysm. We have to recognize, right? And we mentioned about cancers that can happen. And then non-mechanical things were cancers of the bone itself or things that have metastasized to the bone, right? They have signs of SIRS, right? Someone shouldn't have lower back pain and a fever. That's usually an infection, right? They might have lower back pain because they're stiff and they're in a bed for 2 days, but like they present with lower back pain and fever, that we got to make sure there's not a infection somewhere, right? Those are red flags you can't ignore. All right, so lower back pain symptoms. Okay, so red flags we mentioned, right? Those are the tuna fish is the mnemonic for that. These are things you can't ignore. And do they have osteomyelitis or an infection? Do they have a fracture that we got to fix? Do they have a cancer history? That might clue us in that these might be causing the lower back pain. Otherwise, 70% of the time is just something mechanical. They have a muscle strain, or they might have a little bit of herniation, and the herniation might fix. But if that herniation is causing compression of the spinal roots, right? It can cause pain that shoots down that spinal root down to that right leg or left leg, if we're talking about lower back pain. Or it can compress directly into what? Into the spinal column itself, right here, right? Compressing the spinal cord, and now left and right are done, right? And there's lower back pain if we are, like we mentioned, S1 is the perineum, and for incontinence, that can cause that to happen, right? And that is a worst case scenario. That's called cauda equina syndrome. So cauda equina is it's Latin for horsetail because the end of your spinal cord looks like a horsetail. So they call it a cauda equina is the horsetail is being compressed, right? So the end of your spinal column is being compressed and you get all the symptoms of a compressed lower spinal cord. So we mentioned the lower spinal cord is for not only for sensation, but also for motor. So motor-wise, we have incontinence, right? And then pain-wise or sensation-wise, we can't feel our saddle, right? Our saddle on our horse. So the saddle being our perineum and our butt, right? So we have butt paralysis, right? So we have butt paralysis and the mnemonic is spine. So we have saddle anesthesia. They can have some pain in there. They have incontinence. They got numbness. And that is an emergency. That is, you can't just say, just wait 4 weeks, you'll be fine, right? That's not okay. So that is something that's the highest risk complication, one of the highest risk complications you could get with someone that has a herniated disc or spinal stenosis or a subluxation or age-related changes or arthritic changes, right? These are all worst case scenario, right? Before it got to that though, when you have like a herniated disc that's herniated onto one of the spinal roots, like over here, right? So here's normal right there in the bottom right, and then here is a spinal cord that has been not compressed, but one of the spinal roots on the left and right, right? So here's on the left, here's on the right, correct? Right? So that spinal root on the right is getting compressed because it's herniated, the disc is herniated, and it's compressing that spinal root. It's going to cause symptoms down that nerve, right? And that nerve could be the sciatic nerve, that nerve can be the pudendal nerve, that nerve can be any one of those nerve roots, right? But you're going to get symptoms, especially if it's lower back pain, that's going to be down that nerve, right? It could be pain, right, like sciatic pain. It can be a paralysis where you can't move your right foot. It can be weakness, right, would precede paralysis, right? And that lower extremity is might get numbness and tingling and lead to no sensation and no reflexes. And obviously that is a progression that is not okay. So usually when someone has radiculopathy, radiculus is the actual nerve root. It's Latin for, that's what it's called. So radiculopathy is disease of the nerve root. So radiculopathy is very, very concerning, and that needs to be addressed, right? Because it can lead to permanent changes, permanent weakness in the extremity, permanent anesthesia, or permanent flaccidity of that extremity, right? So increasing radiculopathy symptoms are a red flag as well. Or I shouldn't say red flag, because red flags are reserved for like the worst case scenario, but it's very, very concerning if that keeps progressing, okay? So over here, we have all back pain, right? So all back pain has what? Has dull, acute pain, right? It's the lumbar region, right? 85% is very, very non-specific. Don't know what caused it, right? but you got pain with movement and activity. The range of motion is decreased because it hurts, right? So they might relieve it by rest and maybe extending their spine. What's an extension of the spine? Perform an extension right now. It's going backwards, right? Put your head backwards. That's an extension of your cervical spine technically, but your lumbar spine is extending, right? And it usually helps, right? That unherniates the disc, right? If a disc herniated because you were compressing it and it popped out, if you extend, you're going to make it, hopefully make it go back to where it was, right? So extension can help. So muscular lower back pain, that's just they move funny, they have a strained muscle in the back, and that's usually, you can detect it because if certain muscles are sore. If certain muscles are sore, that can be a problem of, it's a muscular problem, right? That's like 70% of our problems, most commonly, right? And then we have herniated discs, which is super common as well, and that's where you have a popped annulus, right? Your annulus, the middle piece right there, has popped out, right? It can pop out onto the nerve root, or it can pop out into the spinal column, which is worse. The spinal columm, right? But if it goes in the nerve root, we're going to get what symptoms? We're going to get ridiculous symptoms. We're going to get radiculopathic symptoms, right? So radiculopathy means what? We have pain, weakness, pins and needles, right? We get pain on that nerve root that is being compressed, okay? And it's worse with sitting because when you're sitting, you're actually putting the most pressure on your spinal cord. I think on the next slide we depict that, right? Compared to standing, there's less pressure on your vertebral column, and if you extend, it's the least amount of pressure. But if you are sitting, that puts a lot of pressure. If you're sitting and leaning forward, it puts up to like 190% more pressure compared to just standing, right? So it's better to recommend extension, right? Not leaning forward. Make sure they have good posture, okay? And then sciatica can result from this compression of that nerve, but sciatica can also result from just the muscle, your piriformis muscle. You might have seen on YouTube piriformis release strategies, right? These are different things that a physical therapist can do, a yoga instructor can do to help you release a muscle that might be impinging your sciatic nerve, okay? So extending, going backwards is a strategy to help those symptoms, right? Compression fractures, not good. You got osteoporosis, we got steroids, we got cancer on there. Those are bad situations, right? So compression fracture, they might have lost height. They might have kyphosis, right? These are symptoms of a compression, right? They have compressed their spinal, the whole thoracic column. And then we have spondylosis. Spondylosis is the water content is less, so yeah, they'll lose height too, but it's due to age, right? And it can then start rubbing on the vertebral column just below it, and it can start leading into a bamboo spine, right? It's going to start causing more and more rubbing, more and more inflammation, and the bone's going to start melting. It's going to start to come together and form together, and then now you're SOL. You really can't fix that without surgery, okay? So they also get like a question mark appearance. So spondylosis, the spine starts fusing together like that, and they start getting bent forward. So they get like a little question mark appearance as a sign that someone has spondylosis. You can probably see this on the street when you're looking at people, they're all bent over, an older person's all bent over. It's not because of osteoporosis, but it's because of spondylosis. That is the water content of those between the thoracic discs and the lumbar disc for that matter are narrowed or lost content. Okay, how do they fix it? They put in little wedges, and they might put some braces, right? Some rods to keep the spine upright. Okay, and that can worst case scenario lead to ankylosing spondylitis. And then finally, worst case scenario, or at less, I guess worst case is tuna fish, and I don't like tuna fish anyways. But worst case is stenosis, right? So you can stenose just the nerve roots, or you can stenose the spinal column itself, right? So the nerve roots, you might get sciatica, you might get radiculopathy. Depends on what caused it. What can cause it is any one of these things really, but most commonly would be the herniated disc. But then we get the spinal cord itself starts getting stenosed, right? And they start getting what's called a shopping cart appearance. They're leaning over, and that's what makes it feel better. If they lean backwards, it's going to start compressing more on the spinal root or the spinal cord, and it's going to start causing more and more symptoms. So usually everything gets better because of extension. The only exception is stenosis, right? In stenosis, their pain gets worse when they are extending because now they are compressing backward into the spinal column, causing more pain. Okay, so that is your different types of lower back pains that we mentioned on the previous slide, and these are their symptoms, right? So here's some diagnostic tests we can do. So PT is a great one to recommend as long as they don't have what? Red flags, tuna fish red flags. Because if the tuna fish red flags, you're not going to send them to a physical therapist. Physical therapist is not going to know how to administer chemotherapy, right? If they have bone cancer, they're not going. They might be on steroids, and we have to, take them off steroids. We have to. What other tuna fish things can happen? They might have trauma, right? And doing PT with someone who has like a traumatic fracture is not going to feel great. Okay, so these are all things we want to get imaging for, basically. It used to be that we got imaging, got MRIs for everybody, right? So we came to lower back pain, everybody got MRIs, everybody got X-rays, everybody got CTs, and it was a huge cost and a huge dose of radiation, for that matter. MRIs don't get radiation, but CTs and X-rays do, right? So that's going to be, if they have tuna fish symptoms now, that's when we get imaging, right? And MRI is our best one, okay? So you get, anytime someone has tuna fish symptoms, they're going to have, they're going to get a MRI, or 6 weeks have elapsed and it's not getting better, right? So, usually all your back pain should resolve in how many weeks? About 4 weeks or so. So after that, if it's not getting better, then we might need to get an MRI. But PT and OT can do what they can, right? They can assess if there's where the impingement is. They can do all kinds of fancy tests. The straight leg test looks for sciatica, where they raise the leg up and it starts compressing the nerve root, and they get pain. They say, well, you have sciatic pain. Let me see if I can do something with your piriformis muscle to fix that, right? So they can do also muscle evaluations. That's to see if someone has radiculopathy. What is radiculopathy again? That's pain shooting down the leg, but what else? Incontinence is going to be cauda equina. That's worst case scenario, right? That's usually the spinal column being compressed. But you're going to get what? Weakness, right? Muscle weakness, and eventually it can be permanent. So we can measure with an electromyogram how much weakness there is. It's an objective way to assess someone's weakness. Okay, we can do nerve conduction studies to see if the nerves are starting to be compromised, and if they are, they need surgery. Right? There's a 100% need for surgery if you have radiculopathy of weakness in one extremity. You want to try to stop that, and then get spinal surgery to avoid further radiculopathy, further weakness, flaccidity, and debilitation. Okay, so there's all kinds of different things we can do. So what's the better one? Extension is going to help, right? And flexion, that's every back pain except for which one? So except stenosis. It's central stenosis. That's when your spinal cord is compressed, right? And then what else? So you see here they got this little boop popping out, right? And it's compressing the spinal cord. And you're at high risk now for what? If you have a herniated disc compressing the spinal cord, not the nerve roots on the side, on the left and right, but the spinal cord centrally, what are you at risk for? For cauda equina, right? Especially if it's lower back pain. Okay, what are symptoms of cauda equina? They might have pain, but it might progress to anesthesia, saddle anesthesia, motor symptoms such as incontinence, right, and flaccid extremities. Okay, so those are different strategies we can do for someone or diagnostic tests as well to see if someone has lower back, what the cause of the lower back pain is. But again, if someone has tuna fish, right, you got to say, A, don't bring tuna fish to lunch, but B, you got to make sure that you are you're getting a imaging study. So an imaging study is necessary to see what the problem is. Do they have a compression fracture? Do they have a cauda equina, right? Usually MRI goes home like at 5 p.m. They usually have bank hours, right, at the hospitals. So the only thing that brings an MRI tech back in is that they have cauda equina symptoms, right? All right, so non-pharmacological treatment. What do we do non-pharmacologically? That's the first thing we recommend, the first thing we can do, right? So non-pharmacological, right, we're going to do what? Be positive. It's like, this sounds really hokey, but being positive actually has better outcomes. It has evidence behind it that if they always say, I'm never going to get better, I have lower back pain, I'm never going to move again, I'm going to lose my job, you're going to have chronic back pain. Congratulations. They're negative Nelly. They are going to have chronic back pain, right? But if they have a positive outcome, positive outlook, and have a good attitude, they will have better outcomes. They will not develop chronic back pain, okay? Lower back pain is rarely life-threatening unless you have tuna fish, right? So having fear, trying to avoid the pain by not moving, that's going to having decreased mood, saying you're going to sue somebody, all that stuff, all that stress is going to cause a development of chronic lower back pain, which is when you have back pain greater than 12 weeks, right? We could do CBT, cognitive behavioral therapy. You can do CBD also if you want, if it helps you. But CBT, that's where you have pain and you are in control of your response to that pain, okay? So exercising, so the key thing with lower back pain is not to not move. You need to move to help lower back pain, as long as it doesn't have tuna fish. If it's tuna fish, yeah, you stay still, we're going to fix you, get you scanned and everything. But if everything's cool, it's been 2 weeks and they don't have tuna fish symptoms, then they need to be exercised. They need to be moving as much as possible, right? And there's all kinds of things they can do. They can move with a person named Mackenzie. Mackenzie was a physical therapist. It's called the Mackenzie method. That's where you do exercises with someone that's hired and covered by insurance too. And why is it covered by insurance? Because otherwise you need surgery, you need medications and other things. So they recommend doing physical therapy. Okay, and then you have an osteopathic doctor that can do all kinds of other strategies to help manipulate and move your muscles and such. You want to avoid aggravating movements, all right? Stay active, but don't do things that are going to cause pain. There's not one of those things where it's no pain, no gain. It's move as much as possible, right? And use what you have. So you can use NSAIDs, you can use, that's pharmacological, but non-pharmacological, we use a hot pack, right? And hot pack is better than a cold pack for lower back pain. Also, we can use a TENS unit. Right, a TENS unit is going to supply more signals than pain signals, right? It's going to confuse the spinal column and reduce your pain, so we can use TENS units, right? Heat therapy, these are all things we can do to fix the back pain on its own, right? There's no evidence it works, but you can do chiropractic, you can do massage or acupuncture, but chiropractic I'd not recommend, especially if you're over age 40, 45. You start getting a subluxation of your cervical discs and you might be decapitated internally. That's not fun. Yes?
What is the difference between DO manipulation and chiropractic?
DOs actually have a medical degree.
Yeah.
Chiropractic, I don't even know what they have. They might have a BSN in like kinesiology, but a DO goes to med school and then one of their paths afterwards, instead of going to neurology, neurosurgery, they go to osteopathic medicine, which is like a 2-year residency. Okay. All right, and then prevention, avoiding the back pain getting worse. So do all the stuff above, plus we want to make sure we're teaching these things. So these are nurse interventions we can recommend. You're going to recommend sleeping prone? No, you're going to recommend sleeping supine, right? Supine with pillows under the legs, that is perfect, right? That's going to be the best thing for the back pain, right? And then do not encourage bed rest for that matter, right? You're not going to be in that position for 10 hours, maybe 6 to 8 hours for a normal night's sleep, and then you're going to be as active as possible. Use heat therapy, use a TENS, use Mr. Mackenzie, use whatever you can to get active, right? So lifting, this is also with someone with back pain, but also just good tips in general, right? So all the different things you learned in fundamentals as far as lifting techniques and strategies, right? What's some tips and tricks? Make sure you got a wide base support. What else? Lifting with your arms and legs, not your back, right? So you're pulling the box up with your arms, and it's close to your body or away from your body? It's close to your body, right? If you have a back brace, you got to pull it out and use it, right? Don't take it off, but use it, right? And please don't do heavy lifting with what? With high heels, right? High heels are not recommended for lower back pain, right? Other things you can do is stay employed, right? That's going to make you happy. It's going to be socially active, be as physically active as possible. You have to be positive as much as possible, right? And there's other things you can do, with your DO, with Mr. Mackenzie. But other things you could do at home on YouTube is do a sloppy push-up, which is called the Cobra maneuver, right? From yoga, you could do the Z fold or knee to chest, the Z line. These are things to help alleviate back pain. We mentioned, if they do need to rest, they should lie down. If you're sitting, you're putting a lot of pressure on your back, right? And if you're leaning forward, right, we mentioned there's 190% more pressure on your back. So that's having a sitting job for that matter is not great, Okay, so what else on this? So these are all different things we can recommend. We recommend yoga, recommend PT, recommend being positive to help someone's lower back pain.
Things I hate as an orthopedic surgeon. Part 15. Chiropractors that tell their otherwise healthy patients that they need to keep coming back indefinitely for maintenance treatments. Now, for most of the people who have mechanical back pain, there are no structural or neurological causes. Research studies show us that greater than 95% of episodes of mechanical back pain will resolve on their own without treatment within 4 to 6 weeks. This just means that most of the people going to a chiropractor would get better with or without chiropractic treatment. So going to the chiropractor, while it may make you feel better, isn't absolutely necessary for the treatment of your back pain. So knowing this, it's especially sinister when a chiropractic therapist tells a patient they need to keep coming back on a weekly basis for maintenance treatment. Bro, no, so you went to a mechanic and he told you that you had to bring your car back on a weekly basis for maintenance treatment. Would you keep going to that mechanic? Think not. You would get yourself another mechanic.
So yeah, so it's not no diss on chiropractic, but it's not evidence-based, right? You can do it, you can do whatever you want, but chiropractic is not a evidence-based thing to do for lower back pain. So it's the wrong answer on the test. All right, so pharmacology, what can we do to fix it? So you did all the non-pharmacological stuff, now the pharmacological stuff. So we give non-opiates, all right, that means NSAIDs basically, right? NSAIDs and Tylenol. These are things we would recommend to stop the inflammatory process, right? The inflammatory process being the release of all these prostaglandins, all these different chemicals, interleukins, all these other fun stuff, and NSAIDs halt that, right? They stop that inflammation and therefore stop that pain. We're going to circle back to these as well because osteoarthritis, rheumatoid arthritis, all these guys use NSAIDs also, right? So we're going to recap on these in a little bit, right? But NSAIDs are going to be, these are over-the-counter ones, aspirin, ibuprofen, ketorolac, naproxen, and diclofenac. These guys are all over-the-counter. There's one that doesn't belong, actually. Either way, these are going to hopefully reduce pain enough so that they can mobilize, right? That's the whole goal, is to mobilize and do their normal activities. If they have to take an NSAID, great, right? If they take Tylenol, it doesn't really work great for lower back pain on its own. You have to combine it with something else. We might combine it with an NSAID, or we can combine it with an anticonvulsant. So an anticonvulsant is blocking the nerve signals in the brain for seizures, but also, or convulsants in the brain, right? Or it's also blocking pain signals, right? So everything else doesn't work, but topiramate does. That's the evidence. So topiramate is or Topamax is the medication that's actually going to help someone with lower back pain, right? It stops the neuropathic pain. Those pain from the extremities or pain from the muscle fibers is going to go into the spinal cord, and topiramate is going to block it, right? So topiramate works right here. That I had it on this. There it is. It blocks sodium channels, right? And it stops that pain fiber. So if this is pain coming in, right? We're going to stop it right there, right? So topiramate blocks that pain fiber from going in. Okay. If someone has chronic lower back pain, they then need to get something a little more fancy, right? So you can take muscle relaxants, but muscle relaxants have a risk of abuse, right? So usually it's like 2-3 weeks just for like acute flare-ups would be a recommended situation, right? And we can give, so muscle relaxants here, they all have a risk for abuse, right? So do opiates, so it's best not to give them and best not to give them together either, right? And they both cause some respiratory depression as well, which is not great. I meant to highlight that in blue too. All right, what else? So non-TCA antidepressants, so they're also going to help with that neuropathic pain. They're stopping those pain fibers from receiving pain, right? Or they're actually stopping the signal from being transduced into the central nervous system, right? So topiramate is an anticonvulsant, and duloxetine is usually the recommended one for neuropathic pain. Okay, other ones don't work. All right, they're the same as giving a placebo, or saline, or high five. It's not going to do anything, right? If you give something else, right? So you know, gabapentin is also on the list. Everybody's GABA at 2 p.m., right? It's 2 p.m. gabapentin time, right? Doesn't work. Anyways, we got other antidepressants, such as our TCAs, right? Non-TCAs. And then we do have the option of muscle relaxants and opiates. They might be on these for acute flare-ups of their chronic back pain. Okay, what else are out there? Local anesthetics, lidocaine patch doesn't work, right? It might have short-term relief, but it's not going to really solve their back pain, like chronic back pain, right? So corticosteroids, like just giving like PO steroids is not going to work, but they can get intra-articular steroid injections. That does work for a month or two, or actually it's like 4 to 6 weeks, right? So that is, lasts 1 to 3 months, local anesthetic. Okay, a little epidural injection of steroids. The steroids are going to stop the inflammatory process right in its tracks, and that's going to alleviate the pain.
There are only 5 over-the-counter pain medicines: aspirin, acetaminophen, naproxen, ibuprofen, and topical Voltaren gel. Which do you take?
All right, so those are over-the-counter ones. The other ones need to be prescribed, all right? All right, our last slide on lower back pain. So this is back surgery. So it's our treatment of lower back pain is through non-pharmacological first, and then pharmacological. And if that's not working, they need surgery, right? Someone has some of the elements of tuna fish, like they have radiculopathy that's getting worse. They got cauda equina. They probably need to go to surgery right away. Otherwise, it's someone who needs back surgery. The pain's not getting better. Usually after a year. That's usually when they are recommended for surgery, but they would get it much sooner if they have other complications, right? So microdiscectomy is where you take a little tube and you go all the way in, and you take out the problem herniated disc, for instance, right? So you just go in there, a little micro removal of the bone, and you take out the problem inflammation, the problem being that nucleus that has pulposed onto the spinal column, right? Or the nerve root. So you can do a microdiscectomy. You could do a laminectomy, where they take out a piece of the lamina, which is the back part of the vertebra, and they just take it out to let it expand, right? So if you have stenosis there, if we take it out, then it can breathe, right? At that point, they can also stabilize it with some rods and pins if they need to, okay? And spinal fusion, that's usually a worst case scenario. That's where they've tried everything else and they need to actually fuse it to make sure it's not, the spinal column is not what's the word? It's not unstable. So we got to stabilize the spinal column somehow, and that's when we progress to spinal fusion. All right, so post-op. Someone gets post-op back surgery. These are things you have to look out for and be alert to and notify the doctor. There's a priority patient you should see first, right? So they have neurogenic shock. And neurogenic shock, you'll talk about shocks in Med-Surg 3, but neurogenic shock here, you just got to know their blood pressure is low. After back surgery, that's not okay, right? It could be because of the pain medications like opiates and such, but usually someone has low blood pressure after spinal surgery. It might be the spinal column is not working. The spinal column not only sends motor and sensory fibers, but also sends what? The SNS out to the vasculature. So everything vasodilates if you can't send the SNS signal out, right? So you get low blood pressure, low heart rates potentially if it's high up, but you lose that motor tone, that vasomotor tone, and you get vasodilation and low blood pressure. So that's a big high alert situation. And then surgical site, you start seeing leakage out of the surgical site. You see blood, you're seeing infection. It's the generic things you see post-surgery. You want to avoid, so you want to notify someone about that, right? And urinary bowel function. So you know cauda equina is a thing, and you should always get better from spinal surgery. If someone came in with incontinence, they should not have continence and then have incontinence again. That means maybe their spinal cord is getting more inflamed, or there's more complications developing. There's blood around the area. There's an infection, abscess around the area. So we always get better with spinal surgeries, right? Usually. So sometimes it takes a while to bounce back, especially if they were severely debilitated ahead of time, right? So they should have a return of bowel function and bladder function. And if they had a situation ahead of time, they might have urinary retention, so we might have to do bowel and bladder training, and maybe even doing a straight cath if they haven't voided in 8 hours, right? So neurofunction, again, always progresses. It gets worse before it gets better. It's always going to be at its baseline, and it will get better. It's always going upright, right? It's always getting better over time. If it gets better, it might be too late, and they got surgery way too late, right? So spinal shock is that's just the time it takes if the spine had an injury, right? They might say, why aren't they walking after surgery? It's like their spine is in shock, right? They are like emotional shock almost. And it takes time for it to get better. Okay, that's different from neurogenic shock. All right, so then maintain alignment. So they got you want to make sure that it's going to heal correctly. So when we turn these patients, we always got to log roll them, right? You learn that in fundamentals, right? We got to make sure we're log rolling all one motion, right? And we have to do what else with these patients? You're going to log roll them, and they're going to get up out of bed, right? They need to what? They need to move. Okay. What else? So microdiscectomy. That's where they're taking a little tiny little chunk out, right? Little sample. Laminectomies are they're relieving the pressure, taking out a piece, and they might have to infuse the bones afterwards, right? And also post-op, we want to assess return of function. And how do you assess return of function? Well, you can assess sensation, right? Bilaterally, do they have sensation? Do they have pain sense? Do they have touch sense, vibration sense? Those are all things the spinal cord will assess, right? And if spinal cord is getting better, those things will return, right? Also, we assess the neurological status to that extremity. They might have pain. These are all your 6 Ps, right? All the things that you assess like neurovascular with peripheral arterial disease. It's kind of the same thing with post-op neurosurgery. So here's the strength I was talking about before. So 5 out of 5 is great. That's normal strength. 0 to 5 is what? No strength at all. They are flaccid, right? So how do you assess someone's strength? So you tell them to push up, right? Press the gas pedals, right? And they're going to push against your hands, right? If one is weaker than the other, that might be the strong one is 5 out of 5, and the weaker one might be 4 out of 5, right? But we have to take away resistance, and so resistance is at 3, right? So at 3 out of 5 is where they can do it on their own, but they can't do it with you interfering, right? So if you are applying resistance and they move both, they're either a 4 or a 5. If they if they can't move one of the extremities, they're okay, do it on your own. Move your foot for me, right? Compress or depress the gas pedal. And if they can, that's a 3 out of 5 potentially, right? A 2 and a 1 is where one's weaker than the other, right? So one might be a 3, one might be a 2. But if you held both, they couldn't do it, but you took away pressure and they're able to move both, and one was weaker, one's a 3, one's a 2, right? A 1 just means they can just move it in the bed. They can't actually lift it off the bed. Technically, you're supposed to have them raise their extremities, and you're assessing or raise their shoulders. If you're assessing strength in the shoulders, or push against resistance. Okay, so that's strength assessment. And dermatomes uniquely are developed like this. Like if you're bent over like that, then it all lines up. When you're assessing dermatomal function, if someone has like an L5 laminectomy, you assess L5 down this region here, right?